Welcome to Together on Tuesday. Today is September 3rd, 2024. And we've come today to talk about what is palliative care, really. So many of us have heard about palliative care, and oftentimes it seems associated with hospice care. So we really wanted to dive into this topic, and we believe these speakers today will be the perfect people to talk about that. Jennifer Seidman and Parvati Krishnan will be speaking today. Jennifer is the Director of Community Engagement for Courageous Parents Network, a nonprofit whose mission is to orient and empower parents and others caring for children with serious medical conditions by providing resources and tools that reflect the experience and perspective of families and clinicians. She brings her experience as an educator and development professional to her role in engaging patient and caregiver organizations, industry partners, and healthcare clinicians. A bereaved mom, she serves as president of Ben's Dream, San Filippo Research Foundation, and has worked with researchers and patient advocacy groups worldwide to fund and advance gene therapies to the clinical trial stage. In addition to co-authoring, supporting families considering participation in a clinical trial, American Academy of Pediatrics Journal, and NeuroJourney, she has been recognized with the Boston Celtics Heroes Among Us Award, Global Genes Rare Champion of Hope, and Sanofi Torch Award. Jennifer received her Master's of Education in Middle School Education from Lesley University. And Parvati Krishnan is a Courageous Parents Network parent champion. She's the CEO and founder of the Krishnan Family Foundation and UDNF board member. She became an advocate and awareness raiser after her two children were diagnosed with multiple rare and nano-rare genetic conditions. She's a passionate and experienced speaker and has spoken at various conferences, workshops, and events engaging stakeholders across the rare disease landscape. She serves on advisory councils as a leader across various institutions and organizations around the world. Parvati has a master's in clinical nutrition and professional experience as a nutrition support dietitian, bringing a unique blend of experience of her work in rare disease advocacy. Thank you so much for joining us. Jennifer and Parvati, I'll just hand it over to you and you can get us started.
Okay, I'm going to share my screen, probably not as technically savvy as your tech person was able to do it. So let me just make sure you're seeing my screen now. And thank you for the introduction, Sarah. It's really nice to be here. And Parvati and I will just maybe personalize this a little bit more for a bit of time. We did an exercise earlier this year when we were meeting as our first meeting of our parent champion programs, where we were asked sort of to define our experiences and how they related specifically to palliative care in 6 words, which is a pretty complicated thing to get done. But what I wanted to share my 6 words with you, and Parvati will share hers, was mine were every parent wants for their child. And I think all of you here today are probably recognizing that for your children. You want them to have good days. You want them to feel successful at school, whatever school looks like for them. You want them to know joy. You want them to experience the things that every child experiences. And I wanted to lead with that because I think really these 6 words capture what palliative care can bring to their lives. So those are mine, and I'll let Parvati share hers quickly.
So much like many of you, I think we are a family with, as you can see in my picture, 2 medically complex children. And oftentimes it's, we don't have a diagnosis. We may not have one specialty. We are seeing so many different places. And the journey becomes so daunting that we have had to reflect. And one of the things that we felt as a family, and I strongly felt, was that the only thing that we had that got us through our darkest of times was hope. And when there's no other answer and everything else is just more questions, we said it doesn't matter, whatever it is, hope is there for us. And so we held on to hope, and that's what got us through our dark times. And much like what Jennifer said, our association with the palliative care team helped us find that hope through our darkness. So that was my 6 words.
So we're here today to talk about palliative care, and I want to start really with the headline for palliative care. And that is, palliative care really helps parents feel that they are being good parents to their children. And in the end, that's really all we can ask, right? That we ourselves feel as though we have been good parents to our children and our children feel loved and beloved. And I think Harvey and I are both here to tell you that palliative care is one good instrument or tool in your toolbox in order to make that the truth for you. And so I wanted to start today a little bit with a definition of what palliative care is, and maybe partially talk about what palliative care isn't. And because a lot of people have confusion over that. So I'm going to give you a little bit of specifics, and then we can talk about it in a more personal manner. But really what palliative care is specialized medical care for people living with serious illness, any serious illness. It is a subspecialty, just like your gastroenterologist is a subspecialist, or your physical therapist is a subspecialist. It's typically delivered by a clinician alongside with your primary care team. And the reason why it's often delivered by a clinician is because it is really about pain and symptom management. It is appropriate at any age and any stage in a serious illness, and it can be provided alongside curative treatment. So let me repeat those things. My son was actually diagnosed with his disorder at 2, or just before he was 2. He did not receive palliative care until he was 14. In hindsight, I wish that I had engaged a palliative care specialist when he was 2, because there were decisions that needed to be made along the path of his life that I think they could have helped with. Instead, we waited until a very big, serious, almost could have been a very life-altering decision that needed to be made for him, was when we actually got a palliative care referral. I want to go back again to this idea that palliative care can be provided alongside curative treatment, because this is where so much of the misconceptions about palliative care happens. So many times we hear at Courageous Parents Network things like, when my child needs palliative care, it must mean that the medical team or me as a parent are giving up on them, because it is so associated with hospice care. But I want to tell you that nothing is farther from the truth. And that's why I put this really great picture on the slide, because you can see here that the mom thinks that she needs to make a choice between curative care or treatment care and palliative care. But instead, what is really the truth is she can walk through both of those doors at the same time. Because palliative care is really about balancing action and acceptance. It's about moving forward, possibly with an intervention or therapy, while at the same time sort of acknowledging the realities and the resulting feelings of the current family situation. And so this is how they help you become a good parent. They help you think about things like your goals of care for your child. And I know when you are looking to your clinicians for anticipatory guidance, that guidance that sort of tells you what's coming ahead and further down the road, and your child is undiagnosed, finding that guidance is really complicated and difficult. And palliative care clinicians are really skilled at sort of helping you find that balance with, what am I going to do, and what don't I know, or what can't be known, and I have to try to plan around it. And that's the sort of balance between action and acceptance that I'm talking about. They're also really good liaisons and really, really gifted communicators. And this can be really of value when you're trying to have a dialogue with all of your different clinicians. And I would imagine, and again, I can only imagine because my child was diagnosed so early in his disease, though many in his circumstance with his disorder are not diagnosed until they're much older than him. That having a gifted communicator who can actually be the conduit between all of these different separate lives that you're living with all these specialists can be really important. And that communication between the different clinicians that you might see really begins with the communication that you have with a palliative care coordinator. Because what they do is they help you define your goals of care, and they can talk to those specialists about your goals of care. So how do they help you define your goals of care? Well, they start by asking questions about your child. They start with who you are, what your family circumstance is. They might ask you questions like, what worries do you have? They might talk to you about things like, can my marriage or my other children survive this? Or how do I tend to both of those things? How will I know if I'm making the best decision? They help you trouble out those kinds of things. These are all about goals of care conversations. And articulating those different philosophies as you're dealing with so much uncertainty helps you begin to get agency in the care of your child. So they sort of back you up beyond how you might be feeling and your own ability to communicate with your child, and really help you have that agency and intentionality in your care. So I'm going to let Parvati actually. Oh,
You just have to click once.
no, I don't know where.
There we go. Oh,
There we go, but not the photo. Sorry, people.
it'll come again. Click again. Click again. There we go.
There you go.
So similar to a lot of the UDN families, we're a family that has gone for medical treatment to various different specialty hospitals across the country. We've gone where we have to go to get the care that our children need. We continue to go. One of the most important questions that we had was, each of these specialists are telling us a different thing. How do we know what my child actually needs today? And I love this visual because most of our life, it feels like it's a bunch of spaghetti noodles. And the palliative care team, and in our case, we also had a complex care team, and you'll hear about it more with Jennifer as time comes. They were the ones that said, okay, you have all of this, but what do you really want? What is it that your family needs? And sometimes the answer was, we just need to get through today. My child is crying. Like, my daughter was very young when we had the palliative care team. She was 2.5. When she was introduced to the team, we had 3 different genetic diagnoses. Yes, we had a diagnosis, but she was the only one in the world with all of these complications that she had. So we were just as good as nobody knew what to do with her. But this team came along and said, diagnosis apart, treatment apart, how can you get through your day? How can you thrive through your day? And so they helped us unpack this bunch of spaghetti noodles into like sizable small portions that we could actually sustain and eat every single day. So that's how I love this visual, and that's what made sense to me, and that's how the team helped me the most. Decision making is often a process. As you know, there's so many different ways you can choose. There's no wrong choice, but every choice has its own consequences, and palliative care teams can help you with that decision. In our case, sometimes it was for both our kids when they were in different hospitals or same hospitals. And so it was, how do we as a family get together on the same page and make decisions? These were not life and death decisions, but these were decisions that would impact our child's care. These were decisions that would impact our quality of life as a family. They helped us look at the bigger picture. Like, yes, okay, today, this team said, start this antibiotic, that team said this, but what is your big picture? Is your big picture you want to take her home? Is there big picture, like getting through the day at home? What was your big picture? So they always brought us back, they grounded us, and they said, put everything aside, how can we help you get by today? And sometimes they helped us just look at the next step. Life got very overwhelming when both our kids were in the hospital. We worked through a lot of questions, a lot of decision makings, and we said we're at a loss of how to move forward. And they said, okay, let's get together and say, what is it that you need to accomplish in the next hour? The palliative care physicians are the teams that actually acknowledge and empower families like mine to say, we do know our children the most. And so that is something that was extremely valuable to us as a family, because we always were questioning ourselves, were we doing this the best? My daughter was nonverbal, my son could tell us what things were helpful. So our questions were always, how do we know we're doing the best? And they were the team that empowered us to know we were doing our best. They also became a sounding board, a team that we trusted, because we could tell them our fears, we could tell them our concerns without being judged. And so we had this team that said, no matter what anybody else is telling you, you can tell us what are your fears, what can we help you with? And that was extremely important to us because they also trusted our judgment when we did make those decisions. As a family, as a care team, we all have different things, biases, we have different opinions we come with, but they helped us as a family get together to say, between the two of you as parents or caregivers, what is it that you want and how can we prioritize it for your children? Today, my daughter is not with us anymore. She passed away when she was 4 years old. She went through all of what Jennifer will be talking to you about in the coming slides, but we're very thankful that we made the best decisions that we could at that time, given all of the information that we got. And we were able to make those decisions and today live with those decisions because we had a very very informed, supportive palliative care team. My son is 16, he's still here, he still has medical complications. He has been with the palliative care team since he was 8, and today they still continue to help us with his care, even though he's nowhere close to hospice care or is nowhere close to dying. Much like Jennifer's previous slide, they help us with curative treatments while also making sure that because it's a life-limiting illness, they can support us with all of the decision making that we will have and the quality of life that we hope for him to continue to have. With that, I turn it back to Jennifer.
Yeah, I'm with Parvati. I really love this illustration that she has here and how the tangled web, as she says, of spaghetti becomes a clear check mark. And in my own personal life, this is also what happened for my son. They helped us at a time when his spinal surgeon was only seeing, what he wanted to see, what his lane included, which is fixing his spine, but not seeing the implications on his neurological condition or all the pieces that made him my son Ben. And it was palliative care that did that. And this is why they help parents know they're being the best parents. And as Parvati says, they consider parents to be the experts on their children. So how is it that it differs? Because we have some limited time today. I want to get back onto hospice care. So how is that different? And what is hospice care and what is concurrent care? I thought we'd talk a little bit about all of those things because there's a lot of confusion out there. Unfortunately, as you guys all know, and as Sarah acknowledged, hospice care and palliative care seem to come always hand in hand. And in fact, the American Academy of Pediatrics calls it the section on hospice and palliative medicine. So they are really married. And why? Some of that is because there's a similarity in what they do. Their real mandate is pain and symptom management. And symptom management doesn't just include physical symptoms. It also includes social and emotional symptoms. And you heard Parvati and I talk about how palliative care are really experts in that. That's how you come away knowing your goals of care, having your goals of care being respected, and you come away feeling like a good parent because they are very skilled at helping you with those symptoms and that part of management. And equally, pain management is a big priority within palliative care. These are true also of hospice care, but hospice care is more specific because it specializes in focusing on end-of-life issues. And this is why palliative care is often confused with hospice care. Hospice care is also an insurance benefit that you can elect to, which makes it slightly different and a little more complicating for palliative care. And as many of you have probably heard, it oftentimes means there's some time limit. In other words, your child must be more likely to only have 6 months to live. Although that gets a little fuzzy along the line because obviously it's not predictable, one. And two, in some areas, and we'll talk about that in a second, hospice care actually does deliver palliative care. But hospice care has no age restriction, so it should be accessible at any age. Now, it can be, and often is, unfortunately, that in many parts of our country, neither palliative care or hospice care at a pediatric level is available because there are so few specialists. So sometimes it is that hospice care for children is delivered by an adult hospice organization. And I mention that because if it is the circumstance where hospice care might be needed in your circumstance, you're going to want to specifically see if you can find a pediatric one, because there are distinct differences between the two. It's also important to note, and this is part of the reason why this little crazy diagram with all the ins and outs of the circles is here, is that because your child is enrolled in hospice care, it does not mean that you cannot still be seeking curative or life prolonging treatments. And this is true in the pediatric hospice realm because of something called the Patient Protection Affordable Care Act, which was passed during the Obama administration. And it allows for anyone under 21 to still be receiving curative or life prolonging treatments while they are on hospice care. And that is called concurrent care. I want you to know the name because it's spoken about in the medical community, and knowing the words and terminology that doctors use is often an empowering act by parents. So that is called concurrent care. Now I wanted to take a minute to just focus on some of the little squirrely lines in this circle. Many children in our lives, and I would imagine many of you, because you have not an official diagnosis for your child. So that anticipatory guidance that I, for example, could read when my son was diagnosed, that his lifespan was likely to be X, and he was likely to encounter Y along the path, helped me prepare. You are in a space where that opportunity is probably a little more fragmented because you don't have an official diagnosis. Again, I stress that palliative care helps you in that field because they are in some ways diagnosis agnostic in that they want to find and get to your goals of care. But children who are complex often travel in and out of all of these systems. You may be seen by a complex care department, as Parvati mentioned her children were. Oftentimes, a palliative care provider sits on the complex care team, but you may not be seeing them because they may look at the symptoms of your child and not understand that it might be a necessity. You can ask for a palliative care consult from your complex care team or any other specialist that your child sees, and understand if palliative care is the right fit for your family. Because again, I want to stress that palliative care isn't just about medical symptoms, it's also about those psychosocial symptoms, and you might need that support through palliative care. Some children, and in some states where palliative care is less accessible, might get many of the services offered through palliative care through a hospice care situation, and travel in and out between all of these different types of care in the system. Parvati, and maybe you could just talk for a minute about that transition that you made with your daughter.
Yeah, when we were originally, we were not said, oh, you should be a palliative care team. Our daughter saw she was 2.5 at that time, and she saw every single specialty that was there in the hospital except OBGYN. So from head to toe, we had a different specialist, and we were so fortunate that her oncologist said, oh, I think you should see this team. And we said, oh my God, one more doctor. It was not until we went, it was called the complex care team. And it was a group of doctors that basically say, okay, bring them all together. Let's get them all and see what is everybody telling us and what does the child actually need. And so we were so fortunate to have that team, because then we would just go to them and say, can you please help us figure out how to make all these different appointments and how to do all of this? And that team has a social worker, a nurse coordinator, and a group of physicians that are the ones that actually answer the calls, like after hour calls, and help us with admissions or helping us stay back. As she got more sick, and as we had to make more tough decisions, they were the ones that actually introduced us to palliative care. So it was a very smooth transition for us, because at that time, we'd already trusted our complex care doctors. We had worked with them. And so when we were introduced to palliative care team, it was not, your daughter's dying, so you're going to be, we want you to talk to this team. It was more, we think that this team can help with some issues that we are not able to help you at home, specifically pain management and thriving at home. And we were having multiple admissions to the hospital. And then we worked with them for another year. So by the time we were actually introduced to hospice care, and when we had to sign forms that you know, we were not going to do DNR, and it was called the most forms at that time in our state. We did all of that, and we did that because we had this team with us that kept talking to us about what are your goals of care, what is it that you would want for your child, what are treatments you would want, and what are treatments that you would not want as a family. And so for us, it was always, we could always go back to the complex care team if we wanted, and she received treatment, including the time up until we had done hospice care for her. So we were very fortunate to have that ecosystem within our hospital, where she was not getting her primary care there, but our complex care team was local, to where we stayed in. So that became our lifeline for everything that we had to coordinate. Our son gets treatment out of state, and our palliative care team continues to be our primary care team right now, where we are.
Great. So we always get this. So I wanted to just acknowledge some realities. Access to palliative care really depends on where you live. In many instances, an inpatient referral is most common. So if your child is hospitalized, that's a great time to actually get into a palliative care department. In some areas, palliative care is hospital-based. So for example, I live just outside of Boston, and my palliative care team was based at a major medical institute. And typically I had to go there to interface with them. However, there are some community-based palliative care programs in the United States. And oftentimes those programs have the capacity to come into your home. So really helpful for the siblings, providing, music therapy, sometimes a bunch of different therapies and things that you might get access to that might benefit not only your medically complex child, but also your family as a whole and your well children. And I just listed the states here that have strong palliative care benefits. That doesn't mean other states don't. These just happen to be the ones that have exceptional ones. So what do you do if your child, if palliative care sort of isn't near you? First of all, the one thing you can do is keep asking, because the more that your hospital institution understands that it's a priority for families, the more likely it is. Look for a champion. So palliative care came to me through my GI specialist. He was the one that recognized and was having those sort of palliative conversations with me, and realized that I had crossed into a decision point where I needed an extra layer of support. And that's what palliative care gave me. But sometimes you can get the same type of help through another clinician. And as Parvati mentioned, if you're already enrolled in a complex care, and probably UNDF in your specialty clinics probably have access for some really good champions. The other thing that's really good to do as parents to help you access palliative care more seamlessly or find a champion is really know that language. And that's why I said I wanted to mention what concurrent care was. So educate yourself with language like baseline goals of care, quality of life, anticipatory grief. These things will help you have those conversations with clinicians that might be different subspecialists and help you access palliative care. You can learn more about palliative care at Courageous Parents Network. It's courageousparentsnetwork.org. We have just a simple list if you just want to read some facts about what palliative care is. We have 2 guides on understanding what the 2 situations are that you can read. We actually have what we call a pathway, and it's like a little learning curriculum where you can read, watch, and listen about complex care, and then a whole library of videos that you can watch, 55 of them, as a matter of fact, that you can watch to hear from other parents about their experience with palliative care. And I really love the videos on our website because it's almost like you get to try on different hats. You listen to one parent and it may resonate with you, and you may listen to another parent and their experience may not. And you can like take that hat off and put on a new one by going to the next video. And listening to this helps you establish your goals of care, which of course will help you feel as though you are being the best parent to your child. So do lean into Courageous Parents Network. to find some resources. We have a lot of other great resources on decision-making and other things that I'm sure that you would benefit from. I'm going to skip over this slide because I think this is the where we should end, and then I'll go back to the one where you can get in touch with Parvati and I. But I think the best advice that my palliative care doctor ever said to me is, I wish I had said this, but she said it to me, is that we make decisions in two places. We make them with our hearts and with our heads. And I think it is often the case when your child has medically complex issues, we tend to rely on our heads. We have to. We're in a position where things are urgent, they're complicated, and we have to. But the real truth is that a lot of the decisions, and a lot of times when we have a regret over a decision, the place that that lives is in our heart and not in our head. And palliative care really helps families to listen and respect both your heart and your head in the decision-making process, and develop your own goals of care. And I think, again, as I said, the headline of palliative care is it really helps parents be the best parents they can be. And part of that is listening to both your head and your heart in the decision-making process. So I'm going to go back to this last slide. And this is really just how you can get in touch with Parvati and I. I put that little briefcase up there because it was supposed to look like a toolbox, but everybody tells me it's a briefcase, because I want you to know that we're now tools in your toolbox, and you can always reach out to the two of us to ask some more questions. I hope that you would consider joining CPN. We'll get just a few emails that might be useful to you along the way in the course of a year. And we were happy to present here today. So I'm going to stop sharing so that we can take questions.
Thank you so much. Really wonderful information. If anyone has questions, you can put it in the chat. We did have some questions come in with people that registered. So my first question is actually third in my list of questions. I'm curious, how often do you visit your palliative care doctor? Specialists often you see every 3 months or 6 months. How often is it that you see palliative care doctors?
Do you want me to go first? Sure. So I don't have a recommendation for how often. I think it is really based on unique situations and your child. It may be if you're traveling to a hospital for an appointment. Let's just say that you're going to an appointment with your GI doctor. You may ask your palliative care specialist to join in on that appointment. So it doesn't always have to be a separate appointment. They can be part of the team. The complex care team can coordinate. And I guess if I think in hindsight, so my son's disease was progressive in nature. If you had met him when he was 3, he might seem like a typical 3-year-old. But by 14, he was wheelchair bound and had very little language. How would a palliative care team have helped me early in my son's diagnosis? It probably would have helped me to have those conversations about where are we going along the way. A good example of that is right away, I said to myself, I'm never going to give my child a feeding tube. At diagnosis, he was still eating like a regular kid. There were a lot of transitions in that period of time where I needed to rethink that decision over and over and over again before he was 14 and I finally got into palliative care when we were deciding to fuse his spine or not, and that had become a layered conversation. I could have benefited with a check-in periodically. The other thing I wanted to, and this doesn't exactly answer the question of how often do you see the person, but I went to my GI doctor and was talking to him about the reality that my son might need his spine fused. And what I said to him was, I'm worried about how to include my other 2 children as we're making this decision, because this surgery could, in fact, end my child's life. And he heard a different layer. He heard, oh, this has nothing to do with medically what's happening with this family and this child, this specific child. This is happening alongside. It's all of the other things that I needed support for. And he heard that, and that's when palliative care came in. And if you think about that, all along the path of his life, my son Ben's life, we could have been using that extra support with those other things, the things that the medical community kind of often doesn't pay attention to. Like, how am I going to make sure that my other two children who are young, younger and older, but still very young, understand the gravity of what we're doing? And so I think it's really individualized to the circumstance. But again, I stress there's no time too soon to do it because you're already developing your goals of care. And maybe Parvati, you probably have more specific examples.
I think it really depends on the acuity or the seriousness of the problem that you're dealing with. So in our case, when our daughter was introduced to a complex care team, we were going to the hospital 4 times a week for various procedures or treatments. And so we then requested to see the complex care team at least every month so that we would have like a check-in point to say this is overwhelming or this is what has happened in the past month. She was also admitted very often. And so that was when we started requesting. In fact, we said we don't want one of the specialty teams admitting her. We want general medicine admitting her because then our complex care doctors could take over because they were general medicine attendings at that time. And so that was hugely helpful to us because when you go in for an admission with such a medically complex loved one, when they're trying to fix one problem, literally it's a domino effect and everything falls down. And the admitting team, I don't know if it's neurology, they have it. They know what to do if it's a GI issue, but it takes a lot. And then we started having a lot of cooks in the pot. And so then we, as a family, requested that we have a gen med team join because they would look at the big picture and they would look at the complex care team and they would ask the palliative care team. So there were times when we met them every other week or every week if needed. If our daughter was acutely ill, we would say, you know what, we need you guys to step in. In terms of palliative care for my son, he is what I would call a chronic palliative care patient. There's nothing actively going on right now. So we see them twice a year where they check in, knowing that at any point we can call them and we can request them to come if things change, if we have a new diagnosis, if we're dealing with something. But there's been an 8-year partnership with that team. Which text them and say, something's coming up or the doctor just told us a bad news. Can you just join us and have a meeting with us?
That's really,
and so it varies to Jennifer's point.
well, and that actually brings me to kind of it's a nice segue to my next question about, I know you had a slide and maybe I missed it on the slide about how you can access palliative care, and oftentimes people do it when they're inpatient, but say if, I don't know when your son accessed palliative care, but and I think of my daughter's own instance, like she is infrequently in the hospital now, but it's because she has treatments that keep her out of the hospital. And so how do you access palliative care if you're not in the hospital? Do you just ask for a referral from your general pediatrician, or how does that work?
So yeah, you will need a referral. And you can ask your pediatrician if that's the person that's your, I would say, your most trusted confidant. That is not always the case for everybody. Like in my instance, it was a different specialist that I got the referral from, my GI doctor. So I think it's the person who's most likely to have those sort of goals of care conversations with you as you're talking about care for your child. Because they're the ones that are going to understand why palliative care might be the next step for you. If you're seen in a complex care department, you can just simply, they likely have a palliative care person who sits on the team, but that person may not have been introduced to you yet. So you can certainly do that through your complex care department. But that's how, and I would imagine for some families without a diagnosis, you may have to ask more than once to get to palliative care because pediatric palliative care teams are overloaded. There aren't enough of them, to be honest with you, which is why I also encourage parents to look for that subspecialist who might be palliative minded and champion some of those activities with you.
I just want to add that not all teams that care for you may be open to palliative care. We had already been exposed to palliative care and hospice and all of that. And I remember one admission when we traveled up north and we were in this admission and a week had already gone and I was getting extremely anxious because I could see all the dominoes starting to fall. And so I requested the charge nurse to say, I need a palliative care consult. And they looked at me and they said, "Oh no, like nothing's happened, nothing's changed." And I said, "I know my child's not dying, but I really need to see the palliative care team of the hospital." So sometimes it's a matter of perspective. Sometimes it's a matter of saying, like, we just need this extra team to come in to help us. And it, like Jennifer's point, it may take more than one time to ask. Just find the right doctor that understands that you're asking for the right reasons, and that's okay.
Excellent. Well, thank you both, Jennifer and Parvati, for coming to speak with us today. If people want more information, they can email, is it Jennifer@courageousparentsnetwork.org?
Yep.
Did I memorize that correctly? And
You
then
did.
Parvati, PARVATHY at Courageous Parents Network. .org. Just making sure I got all those in the right order there. So anyway, thank you so much for your time. And we have we will end with a video. Michelle Herndon, who is our patient navigator director here at UDNF. She will be talking via recording, pre-recorded message about her experience with palliative care. So please stay on while that plays.
Hello, I'm Jennifer Tussaud, one of the patient navigators here at the UDNF Patient Navigation Program, and I'm here with our next guest, Michelle Herndon. Along with her nursing background, Michelle is also our Patient Navigation Program Director and also the co-founder and vice president of the Mitchell and Friends Foundation. She is also mom to Mitchell, who for many years battled a mysterious neurological illness that at first had no name or treatment. And after going through the Undiagnosed Diseases Network program, his condition was discovered and named Mitchell syndrome. Welcome, Michelle.
Thanks for having me.
We're glad to have you here today. First, can you tell us a little bit about Mitchell?
Sure. So Mitchell was our oldest child. We had 2 sons and a daughter. Mitchell passed away in 2019 at the age of 19. It's always easy to remember how old he was because he was born in 2000. So that was easy math. He was a normally developing normal kid until he was about 12, and he started having some unusual symptoms with balance and hearing loss. And to make a really, really long story super short, he had about a 5 or 6 year diagnostic odyssey, being treated and seen by some of the best physicians in the country. They could not figure out what was causing this. They thought it was autoimmune, thought it was something genetic that hadn't been discovered. And ultimately, through the work of the Undiagnosed Diseases Network and the team at Baylor College of Medicine, they determined that it was a new mutation on a gene called ACOX1 that was causing all of his symptoms. And we ultimately then found other patients around the world with the same mutation.
Well, thank you for sharing his story with us. I know that with a lot of his neurological symptoms, he was probably like in a wheelchair and had trouble with just day-to-day functioning. And that's kind of what we're here to talk about, is having palliative care to help with some of those things that you have to live with day to day. But first, I wanted to find out your experience with palliative care before this experience with Mitchell. Is that something you already knew about as a nurse, or is it something you learned along the way with Mitchell?
Yeah, that's a great question. I mean, I think I obviously knew what hospice was. I feel like that is the word that's like gotten, well known to everybody over the last few decades. And we all know what hospice is. My father passed away, with care of hospice, and they were so helpful. And I think that is always what we kind of thought. And then palliative care grew out of that. And I don't think I had a full understanding of what palliative care was. At the hospital that I worked at, we had a complex kind of pediatric advanced team that would work with patients who had complex medical conditions. But no, even as a nurse and right kind of up until we got palliative care involved, I don't think I really knew everything that they did.
So how did you first get palliative care then? Was this something that you asked for? Was it doctors that told you maybe you need this?
Yeah.
Was it something Mitchell realized he needed?
Yeah, that's a great question. In telling you more about Mitchell, I probably should have also been clear that, Mitchell, like I said, was developing normally. He was your normal teenager. Other than this, the balance, the walking, the declining neuromuscular status, he was cognitively a 19-year-old. He was very smart. He had a full ride to St. Louis University. So, it was not a, a situation where, I had, guardianship over him after he turned 18, and he was mentally, in charge of himself. And so that adds a little layer to this whole situation. He wasn't, a minor child, that I was directing all of his care. So as he got a little older, being a nurse, his condition started getting a little worse. And this sounds silly, being a nurse, when I look back and I think of this. He was probably 18 or just under 18, and maybe in his senior year of high school. He physically was getting worse. We knew about this gene mutation. We knew, maybe some treatments down the road that might help. But it just got to where he was getting worse and getting worse. And it finally hit me like, wait, could he die from this? And I know that sounds silly, being a nurse, but no one had ever really point blank said that to me. Like, Michelle, this could end with it affecting his breathing, it affecting, it could affect him cognitively. No one really had ever said that. And in my mind, being a pediatric nurse, I just thought we would cross every hurdle once we got there, right? I mean, okay, need to be in a wheelchair for the rest of his life. We can do that. Okay, he might need a tracheostomy or a ventilator. We can do that. But I never really got to he could die. And it's still, looking back, I just can't believe that I was at that place. But we were always living in this place of hope, of hope that we would find something that would help, hope that he would stabilize and stop getting worse. And, like I said, about a senior year of high school, I started realizing that might not be a possibility. And I remember asking his neurologist, do we need to think about an advanced directive? That was the first time I ever thought about that. And I think at that point is when she started to think, okay, I think we probably need to get palliative care involved. So it was the neurologist who had cared for him since he was 12 and had, spent nights not sleeping, thinking about him and what she could do to help him. And she was eventually the one that said that palliative care should come in and help us.
And I think that probably speaks to a lot of the undiagnosed in our audience, what you experienced of there wasn't a prognosis.
Right.
So there wasn't a plan in place for you. You didn't know ahead of time, yes, you were going to get to need this or not going to need that. So I think that's really going to connect to a lot of people who are in that undiagnosed path right now. Once you've got the palliative care, what was that? What did they do for you? Who was on the team?
Yes.
What did it look like?
So when palliative care got involved, Mitchell was 18. So, the first of all, the team came in and I'm sure I was pretty mama bear. If you ask them, they probably have funny stories about me, I don't know, being overly involved. But, we really wanted them to, and their directive is to, serve the patient. And since he was cognitively appropriate, what were his needs? What was his wishes? And once Mitchell explained to them, my mom really is my main voice and advocate, and, she is my decision maker should I ever not be able to make decisions, then they, would talk to me as well. But their first priority was, Mitchell, what do you want? How can we help you? And so they first kind of got to know him. The thing that was really the best for us was kind of figuring out what Mitchell's goals were. And Mitchell's goal was he wanted to go to college. He wanted to live on campus. That's what he wanted to do. And so the palliative care team stepped in to help him as much as possible meet those goals. Whether it was, okay, how are we going to get the catheters that he needs delivered to a dorm room at college? How are we going to, what medicine maybe should we think about him being on so he doesn't sleep as much? So they started thinking more holistically about him instead of just the nerve damage and the progression of the disease. It was more, what are his goals? How can we help meet those? And then also, how can we bring the family into it as well?
Yeah, I think that kind of gives a lot of hope about what palliative care is, because you hear the term and you do think, I thought hospice, I thought it was kind of
Yes.
similar. And that's more of an end of life stage, but this was more making his life continue the way he wanted it to continue. So
Absolutely.
that's pretty amazing that they were able to get him. He did go to college, correct?
He did. We moved him into St. Louis University, into the dorm. He had a few weeks there of normal freshman shenanigans that, you know, a mom probably doesn't want to hear about. And unfortunately, he did get admitted again to the hospital and wasn't able to complete college before he passed away. But you know, that was his bucket list. And I don't know if this resonates with other undiagnosed patients, but one of the biggest things I regret having no prognosis is we didn't have that, you know, bucket list. Like if you had told me your son is going to die when he's 19, our life would have been totally different, right? We would have traveled the world and showed him all these things that he never got to see, and probably wouldn't have said some mean things that I maybe said because my husband and I pushed him so hard because we thought you're going to be really disabled, but you have goals, so we need to push you. Maybe I wouldn't have pushed him so hard, you know. So there's so much retrospectively that you miss out on because you don't have a prognosis. But then on the other hand, living with hope is good too. And we know there's so much hope for undiagnosed patients. So it's just a different way of living that I think a lot of people aren't used to.
Yeah, that's true. And I think part of his experience is he got to live a normal bucket list too. So
Yeah.
there's definitely value in that, I think.
And that's what my husband always says when I start kind of getting down about it. He says, Michelle, going to college was his bucket list. And we did everything we could as his parents to make that happen. It didn't end up the way we wanted. It wasn't perfect. We have some pretty funny stories about, you know, trying to find patient care aides, you know, and college students. He had, you know, these nursing students and PT students who were his aides that would get paid. And, you know, it was a lot of work, but that was his bucket list, is going and doing that.
That's so good that happened and palliative care helped get that to happen.
Yes.
I know probably a big question also on the mind of our audience, especially for the undiagnosed, is how was this paid for? Did you get insurance to pay for it? If you're undiagnosed, you can't check the box, you don't have an ICD code. Was
Right.
that difficult to get insurance to cover this?
For us, it wasn't. First of all, he had turned 18, so he now had my private health insurance from my job, and he had Medicaid. I don't know if before he turned 18, if it would have been harder. I think the fact that he had Medicaid was helpful. But it wasn't hard for us to get that service in the hospital we were at. I know that there are some hospital systems where it's much more difficult, and there really aren't that many providers either.
Okay, well, that's good that it was an easy process, even undiagnosed.
Yes.
You know, check the box. So one final question I have for you is, what advice or tips do you have to someone who is undiagnosed or maybe ultra rare? You know, maybe there's only one of them known in the world, if they're thinking about palliative care or trying to get palliative care?
Yeah, that's a great question. I mean, my biggest advice is to not be afraid of it, that palliative care doesn't mean the end. Palliative care, they're great at communicating and helping you and your family, or if you're a caregiver to, you know, a child or, you know, an adult and you're their guardian, it helps you to make the decisions that you need to make. Ultimately, you know, Mitchell did pass away, and it was pretty sudden. We knew that he was declining, but it had never gone to his brain, and he was cognitively appropriate the whole time until about the last 2 weeks of his life, when suddenly it started affecting his brain. And if we hadn't had the conversations we had had with palliative care, with Mitchell over the previous year and a half, the decisions that we had to make at the end of his life would have been so much harder. They were hard, but I knew I was doing what he wanted and what his wishes were, because we had those conversations, which would not have happened if palliative care hadn't helped facilitate them.
So that was built into the program to
Yes.
help think about the what ifs.
Yes, they helped us. They had a guide called the 5 Wishes. It has to do with end of life and wishes that frankly, all of us should think about, even those of us who don't have undiagnosed or ultra rare diseases, but it's hard to think about. Nobody really wants to. When you're deteriorating the way Mitchell was, it was in his face and he had to think about it. And they were there the whole way to facilitate it. And then with us at the end, the palliative care physician was with us when our whole family was there with Mitchell at the end. And so they were hugely supportive the whole way, even afterwards, checking in. How are you? They had a chaplain on the team, social worker on the team, physicians on the team. They helped us to know what it would be like, that he would not be in pain. So they were invaluable. And even as a nurse, right? I think people think, oh, a nurse, you know what to do. No, I've never had my own child die in front of me, right? And that's different. So they were hugely supportive.
Well, the ending isn't what we would all want, but I'm glad that the support was there for you.
Yes. Yes.
And I want to thank you, Michelle, for being here today and for sharing Mitchell with us for a little bit.
Yeah.
And this has been really helpful to hear how palliative care helped meet the bucket list and helped support the family at the same time. So we really appreciate you being here.
Thank you for having me. I hope I can share his story and, one, inspire more doctors to go into palliative care. 2, get more hospitals and health insurances to support financially the work of palliative care. And then 3, just really help patients and families not be afraid to go down the path of getting support from a palliative care team.
I think those are all important. Thank you.
All right, that concludes our Together on Tuesday, this September 3rd. And if you want more information about us, udnf.org. Upcoming in October, if you are in St. Louis or Houston, come join us at our in-person event. You can find out more on our website. And in April next year, we will be in the Washington, D.C. area for our first ever Summit 2025. Thanks.